Okay, everyone. I hope the start of your fall break is going well. I apologize for the delay in getting this lecture posted for you. Certainly took some work to figure out technologically how best to do this, capturing audio and video and all of that. But hopefully this is all set and works well for you guys. Definitely make sure that you watch this video before we meet for class on Monday, since we'll be this video will be the start of this chapter 6, and then on Monday we'll wrap it up. So it'll be really important that you have the background stuff before we meet on Monday. So this lecture, we're finally getting into chapter 6, where we're going to talk about panic, anxiety, obsessions, and their disorders. This is a bit of a tough chapter simply because we're going to cover a lot of different disorders, probably more numbers of disorders than any of the other chapters. So I will try my best throughout to help you keep all of them straight, really help you to understand the key defining characteristics of each disorder so that you can kind of keep them straight in your head. But basically, we're going to talk about disorders that are characterized by anxiety, panic, fear, obsessions, those types of things, which roughly kind of fit under the umbrella term of anxiety. So in terms of an outline, today we'll first talk about how to differentiate between fear versus anxiety, because some of the disorders we're going to talk about are more pertinent to fear, some more to anxiety, so it's important that you know the difference. We'll also talk about when researchers and clinicians talk about fear and anxiety-based disorders, what are the main components that they're interested in? There are 3 we'll get to today. Then we'll talk about some key commonalities across all of the anxiety disorders. So obviously we're going to differentiate among them, but we also know because of research that there are a lot of things that are similar. So we're going to talk about comorbidity. There are a number of disorders that frequently co-occur with anxiety disorders. That is, they are comorbid with anxiety. We're going to talk about biological, psychological, and sociocultural risk factors that tend to cross the boundaries of all of these disorders. And then finally, we'll talk about some effective treatments. Now, as we go through the disorders, you'll see how treatment looks different for each, but there are also some sort of commonalities and common themes in the treatments that we know are most effective for anxiety disorders. So we'll talk about those as well. Finally, we'll actually get into the specific disorders, starting with specific phobia. And for each of the disorders we cover, we'll kind of go in this same sequence. We'll talk about the clinical features. This will entail talking about the DSM-5 criteria for that disorder, sort of trying to get a sense of and a flavor for what it looks like in people. So I'll try to show you some clips of folks describing what it's like to have each disorder, so you kind of, again, get a more of a richer understanding of what it looks like in an actual person. Then we'll talk a little bit about prevalence rates, whether there are gender differences, those kinds of things. And then we'll get into different risk factors for each of the disorders. And for specific phobia, the focus is really on behavioral and biological risk factors. And then finally, with each disorder, we'll talk about the treatment approaches that seem to have the most evidence behind them. For specific phobia, that'll be exposure therapy. The other 2 disorders that I'm going to hope to get to in today's lecture are social anxiety disorder and panic disorder. So under social anxiety disorder, again, we'll talk about clinical features, prevalence, causal or risk factors, and the treatment approaches that are most commonly indicated via research. We'll talk generally about what a panic attack is and how that differs from having panic disorder, which is an important distinction for you to make. So not everybody who has a panic attack has panic disorder, and we'll go through that in detail. We'll also talk about a common co-occurring disorder. It's actually a separate disorder in the DSM-5, agoraphobia, but it commonly co-occurs with panic disorder. And again, we'll talk about those 4 key pieces as we will with all of the disorders. So hopefully that will take us to the end of today's lecture. And then in Monday, we'll wrap up the rest of the chapter. Okay, so anxiety versus fear. How do we know the difference? So in general, you can think about anxiety as apprehension about a potential future threat. So you're not immediately in harm or danger, but you are thinking about the possibility of something that could be threatening to you in the future. So you're in sort of this anxious, anticipatory state. In contrast, fear is actually your response to an immediate threat. You are actually in the situation that is making you feel anxious. You feel like you're in some type of danger or you could be harmed in some way, right? Whether that be physically, socially, whatever. So to sort of give you an example, right? So if you're in a car accident, fear is what you experience at the moment of impact. That immediate sort of rush, your heart starts beating, maybe you start sweating, shaking, etc. Whereas anxiety is more the anticipation, right? So maybe after you've been in a car accident, you start to have thoughts like, I don't want to get into all that traffic. What if we have an accident, right? You start getting anxious would be the word, right? So this, I can very much relate to this. I got into a kind of a minor accident maybe about a year ago now, where I was driving, my daughters were in the car. It was very scary at the time, even though none of us were hurt, we were fine, but a semi truck thought he was in a turning lane when he was not. It was actually a straight lane. So he actually turned directly into our car and hit the back of the car, the back passenger door, right by where my daughter was sitting. So it was terrifying, right? This big truck coming at us. We were fine, but I definitely felt fear in the moment. And since then, I still feel anxious anticipation every time I'm passing a semi on I-40 or wherever. I still kind of have this mini flashback in my head of, that feeling of the truck swerving toward us, and find myself sort of gripping the steering wheel a little tighter as we pass by semis, thinking that it might, again, turn into or hit us. So fear was the moment the original accident happened. Anxiety is, anticipating and worrying and being apprehensive about it happening again. So fear, again, just to kind of get into this a little bit further, it's the basic emotion that's found across all species. You'll see this across most animals. And it's basically the activation of your autonomic nervous system, which many will know as your fight or flight response, right? You're in a scary situation, you're potentially under threat. Your body gets activated for you to be able to either fight off that threat or flee and get yourself, safe from that threat. Of course, this has high adaptive value for us evolutionarily. It allows us to escape. It allows us to survive in situations that are dangerous. However, the problem is in fear-based disorders and anxiety disorders, it's really that the fear response is occurring in the absence of any obvious external danger, right? So this is very much related to panic attacks. You go into that fight or flight response in a panic attack, even though there's no obvious external danger to you. So 3 components of fear and panic that we can sort of think about in terms of when you're having a fear response, right? So you have a cognitive or subjective response. So this is sort of what's going through your head. What are you saying to yourself? What are the thoughts you're having as you're in that scary situation? You have a physiological response, right? Your body responds in a certain way. Again, that fight or flight response. And then behaviorally, you get activated to behave in a certain way, typically when you are fearful or panicked. So if you think about the example of a panic attack, what this might look like cognitively, you might feel like you're going to die. Let's say you think you're having a heart attack, which would be a common cognition with a panic attack. You might actually think, this is it. This is really a heart attack. I'm going to die. Physiologically, you might feel your heart rate increase, right? Maybe your heart's beating out of your chest. You may start to hyperventilate. You may start to sweat, for example. Those would be all physiological pieces of the fear response. And then behaviorally, when all that's happening, typically people have a strong urge to escape, right? It feels like I'm in danger. I need to get out of here. Now, importantly, these 3 components are actually somewhat loosely coupled. So they can all occur strongly together, but there might be some situations in which they don't all occur strongly together. So for example, you may cognitively feel really scared. You might be saying to yourself, oh my gosh, something really bad is happening. You might have a strong urge to escape, but actually physiologically, some people may not respond very highly. So that would be a case where these components are more loosely correlated or coupled. Okay, going back to anxiety, right? So anxiety is more oriented to the future, as we've talked about, and it's much more diffuse. It's not sort of this concentrated key, oh my God, I'm in danger right now type of thing. Importantly, anxiety can also be adaptive. We tend to think of anxiety as always being bad. That's not the case. Mild to moderate levels of anxiety actually do some good things for us. So good levels of anxiety can help us plan and prepare for a possible threat. So for example, when you have a test coming up, right? If you are mild to moderately anxious about that test, right? There's a threat of potentially doing poorly. There's evidence that shows that that actually improves your performance. You do better on the test because that anxiety motivates you, right? It gets you moving to study and prepare for the test. Now, the problem is when anxiety exceeds those levels, right? And when your anxiety is too high, that can actually start to impair your performance because it gets in the way, right? It makes it hard to study because the anxiety is sort of, just too all-consuming. So in certain levels, it can be very adaptive. So these three components of anxiety, cognitive, physiological, and behavioral, apply to anxiety in a very similar way that they did to fear and panic. So in this case, when you are in an anxious, apprehensive state, right, some of the cognitive things you might feel, you might have a negative mood, you might be worried, right? There's this general sort of like, oh, I wonder what's going to happen. I'm worried, I'm concerned about this upcoming difficult conversation I have to have with a friend or a significant other, for example. You tend to feel very preoccupied with yourself. You sort of go into yourself, and it becomes difficult for you to be able to predict and control the potential threat that could happen, right? Physiologically, people tend to describe a lot of muscle tension when they're in a state of anxiety and worry, right? So it's not so much that fight or flight, but it's this sort of, I'm over-aroused, I'm sort of keyed up, I'm on edge, I'm tense, I'm restless, those types of physiological responses. And behaviorally, what typically happens when you're anxious is you avoid situations that might be dangerous. So you're not actually in a scary situation that you need to escape, again, because you're anticipating, you're in that anxious, apprehensive state. But you tend to think, I'm not going to go to that party. So-and-so might be there. I'm going to feel really anxious. I'm just not going to go. One of the sort of consequences of being in this heightened state of arousal, this anxious, apprehensive state, is that this sort of primes you for the fight or flight response, right? So if you have high levels of this anxiety and worry and apprehension, when you actually do feel fear or panic, you're very much primed, right? You're more likely to go into that fight or flight response more quickly. Your kind of body is primed for it in a way. So obviously you guys don't have clickers now as you're watching this video, so you won't be able to collect points, but I think it would be still helpful to go over a couple key questions as we're going through the lecture, again, to just kind of test your knowledge, and then I'll make sure to upload these clicker questions later so you guys can use them as a study resource for the second test. So the key difference between anxiety and fear is what? Fear is future-oriented, while anxiety is present-oriented. B is at the opposite. Anxiety is future-oriented and fear is present-oriented. Is it that fear is adaptive but anxiety is not? Or is it that anxiety is adaptive and fear is not? So take a minute to think about that. Maybe jot down your answer so you can just sort of test your own knowledge as we're going through. Okay, so obviously you don't see percentages here, but you can see that B has the green response column. So anxiety is future-oriented while fear is present-oriented. C and D are false because both fear and anxiety can be adaptive in some instances. For someone who's afraid of snakes, the strong urge to leave the reptile room at the zoo represents which component of fear? Would that be the cognitive component, the subjective, the behavioral, or the physiological? Strong urge to leave, right? So this would be escape or avoidance. So again, take a minute. Okay, and as you can see here, the answer is C, behavioral, right? Behavior, what your body does, right? You want to leave, you have this urge to avoid. Okay, so that's sort of the background of fear versus anxiety. What about anxiety disorders in general? What are some of the commonalities that we know about? So in general, the anxiety disorders tend to be framed around concerns that are either unrealistic or irrational, or sometimes both. It can be fears or anxieties, or sometimes both, depending on the disorder. But always, just like all the disorders we'll talk about, the person will display either distress or impairment because of the fears and anxieties that they're experiencing. And oftentimes you'll see both distress and impairment present. So as a group, I'm going to try to kind of sell you in this slide on why anxiety disorders are important, why we should study them and know more about them. So anxiety disorders are the most common group of psychiatric disorders that you see. So lifetime prevalence rates, almost 30%, so about 1 in 3 people will have an anxiety disorder at some point in their life. If you look at the prevalence rates across 1 year, it's almost 20% of people, so quite high. These disorders are associated with a host of detrimental outcomes across social, occupational, and educational domains. So we see things like higher rates of teenage pregnancy with anxiety, higher rates of suicide, higher rates of high school dropout. We see lower educational attainment. We see peer problems, lots of difficulties for individuals who tend to suffer from anxiety. We know there are a lot of medical conditions that commonly co-occur that are associated with anxiety. So you're more likely to experience things like chronic pain, irritable bowel syndrome, hypertension, cardiovascular disease. If you are anxious, again, those medical conditions co-occurring with anxiety disorders. Let's see. These disorders also have the earliest age of onset of all of the groups of disorders that we'll talk about. So these tend to present the earliest in life if you look across the lifespan, which has led some people to think about anxiety disorders as potentially a gateway disorder, right? So some people will talk about alcohol or marijuana as a gateway drug to harder drugs. Some people think about anxiety in a similar way, that it is sort of a gateway disorder to later, more severe, potentially psychopathology. So what disorders might follow anxiety disorders? If you think about, so if anxiety disorders present early in childhood, early to mid to late childhood, what are some other disorders that might follow? Looks like I don't actually have that on the slide. And we're going to talk about it in a second, but some of the common ones we've talked about: depression, right, co-occurs highly with anxiety. Alcohol and substance use disorders will typically onset a little later than anxiety, and folks have noted a connection there that people use those substances as a way to cope with their anxiety, right? So those are the two biggest ones to think about: depression and alcohol and substance use. What about the actual disorders? So the ones that we're going to cover are specific phobia, social anxiety disorder, and panic disorder, and agoraphobia, all of which we'll talk about today, hopefully. Then next time, we'll get into generalized anxiety disorder. So these disorders differ in the extent to which they're characterized by fear or anxiety, and really what the focus of the anxiety or the fear is, right? So that'll have a different focus in terms of what the person is worried or scared or anxious about, but there's a lot of commonalities across them, as we're going to talk about. One thing to keep in mind is obsessive compulsive disorder, OCD, which we're also going to talk about in this chapter. It is no longer under the category of anxiety disorders in the DSM-5. So it used to be an anxiety disorder. Now it's under its own grouping of obsessive and compulsive related disorders. So we will cover it in this chapter. It's just in a different DSM-5 grouping. Okay, but before we get into all of the specific disorders, let's discuss important similarities in the basic causes and treatments of these disorders. So I just hinted at this a little bit. 3/4 of those with an anxiety disorder meet criteria for another disorder. So it's actually fairly rare for somebody to present with just an anxiety disorder. The biggest comorbid disorder is major depression, right? 60% with an anxiety disorder will meet criteria for a major depressive disorder. And other disorders that we'll commonly see co-occur are substance use, as I mentioned, which alcohol is subsumed under substance. And we also actually see a fairly high rate of personality disorders as well, which is a chapter we'll cover later on in the semester. Okay, what about biological risk factors? What are some common genetic, biologically based risk factors across these anxiety disorders? Well, from a genetics standpoint, it seems like people who inherit a general vulnerability for neuroticism from their parents are at higher risk for anxiety. And you can sort of think as neuroticism as the general proneness to experience negative mood states. And so neuroticism is a risk factor for both anxiety and depression. And it does seem to have a pretty strong genetic heritability component to it. So this is common across all the anxiety disorders in terms of a risk factor. And then the neurotransmitters that we're going to talk about that are common across all of the anxiety disorders, we're going to talk about GABA, norepinephrine, and serotonin, all being some common neurotransmitters that come up in terms of basically there being some issue with the overall level, right? There's too much, there's too little circulating in the brain, and that's what's potentially a causal factor in these anxiety disorders. We will also talk a little bit about brain structure and function as a risk factor for anxiety disorders. And in general, what we see is folks with anxiety tend to have an overactive amygdala, that sort of portion of their brain. The amygdala is sort of thought to be associated with emotional reactivity, right? So if your amygdala is overactive, right, you're more likely to react strongly to emotional stimuli, etc. In addition to that, folks with anxiety disorders also tend to have an underactive prefrontal cortex. So the prefrontal cortex part of your brain is highly implicated in emotion regulation. So this is the part of the brain that is supposed to sort of come online and down-regulate those strong emotions that you're feeling, right? So if you have an overactive amygdala, it's not so bad if you also have a good performing prefrontal cortex, because that can sort of come online and down-regulate that emotional reactivity so that you can cope. The problem with anxiety disorders, of course, is it's a double whammy. Your amygdala is overactive, so you are responding strongly in terms of your emotions, and then your prefrontal cortex isn't kicking in the way it should to help you down-regulate those emotions, and so you're left with this excess of sort of emotional reactivity. Okay. So quick question, in general, anxiety disorders are associated with upregulation in the amygdala and downregulation in the what? Is there downregulation in the limbic system, the prefrontal cortex, the hippocampus, or the temporal lobe? And downregulation, you can think of sort of underactivity or underactivation. So take a moment with that. Okay, hopefully most of you guys got that. We just talked about it, right? Prefrontal cortex isn't coming online the way that it should. In terms of psychological and sociocultural risk factors, right, classical conditioning is going to be a common theme that we're going to talk about across a number of the anxiety disorders. So for a lot of them, it seems like there was an early conditioning experience where someone learned to associate a certain cue, right, with fear, anxiety, panic. There also tends to be across the anxiety disorders low levels of perceived control in anxious individuals. So perceived control is the belief, if you have low perceived control, it's the belief that you lack control over your environment, right? So you tend to operate under the assumption of there's just not much I can do, right? Bad things are going to happen and there's nothing that I can really do about it, essentially, right? I just don't have much control over the things that happen to me. We also see a number of cognitive biases present across the anxiety disorders. So we see this tendency for selective attention to threatening stimuli in the environment. you take someone into the lab and you present them with competing images, right? Some that are negative, some that are positive, or sometimes it'll be negative versus neutral. Anxious individuals are more likely to pay attention to the threatening or negative stimuli compared to non-anxious individuals. And we also see an interpretation bias, which is the area that I study quite a bit in terms of cognitive biases. So if you have an interpretation bias, your tendency is when you're in a situation that is sort of uncertain or ambiguous. So there could be some threat involved, but it's not really clear. Anxious people are much more likely to interpret those situations in a negative, anxiety-producing manner, right? They see threat in ambiguous situations, whereas non-anxious individuals tend to not see threat, essentially. And then we also see this pattern in terms of sociocultural environment where people with anxiety disorders will be more likely to recount several negative life events that have happened to them. The idea being that having these events happen early in life may sort of set up a vulnerability, right, or a predisposition to develop anxiety later on. So one thing to keep in mind, like all of the disorders we'll talk about really, right, is going back to that early chapter 3, I believe, the biopsychosocial model is really important here, right? It's likely a combination of many of these factors for people who have anxiety disorders, biological, psychological, and sociocultural. Okay, so what do we know about effective treatments across the anxiety disorders? Well, graduated exposure or exposure therapy will be a common one that we talk about a lot, right? That this tends to have a lot of evidence behind it as being highly effective for people with anxiety disorders. So the idea here is that you expose yourself to the situation or the object that triggers your anxiety or fear. And not only do you expose yourself, but you stay in that situation until you habituate, right? Or until your fear goes down or decreases. So this is exactly like what we talked about last class with exposure therapy for PTSD, right? So we talked about Jason, my client who had PTSD, right? So he listened to the memory of his trauma over and over again until his fear habituated or decreased. And then he exposed himself to all the external cues or triggers that he'd been avoiding, again, until his anxiety went down. We're going to see very similar treatment in the other anxiety disorders here. Cognitive restructuring is common, right? So trying to figure out, are there ways that these individuals are thinking about the things that make them anxious or fearful that are really counterproductive? And can we work with those thoughts and sort of make them more adaptive for these individuals? And then we'll talk about common medications that are prescribed for anxiety disorders and what the evidence base is for those. So the main ones being anti-anxiety medications and antidepressant medications. Okay, so that brings us to specific phobia. So the first anxiety disorder that we'll talk about. So the criteria here, according to DSM, right, is that the person has a marked fear or anxiety about a specific object or situation. So picture here would be snakes would be a common one, right? Spiders. We'll talk about some of the common manifestations. The object or situation, whatever it may be, it has to almost always provoke immediate fear in order for it to be a phobia, right? So we're not really talking about something here that I'd rather not be around it. Sometimes I'm okay, sometimes I'm not. This is almost always an immediate fear response to whatever the situation or the object is. The person with the phobia will either actively avoid the stimulus, or if they have to endure it, if they can't get away from it for whatever reason, they endure it with intense fear, right? So it's not like, oh, I can stay around it and it's fine. It's, oh my God, if I have to stay in that situation, I am terrified. The fear that they exhibit has to be out of proportion to the actual danger posed, right? So some snakes are dangerous. Some spiders are dangerous in terms of some of the fears that we'll talk about. Some heights can be dangerous, right? So the person's fear has to be out of proportion to whatever the actual danger is that's associated with the stimulus. The fear has to be persistent. So according to DSM, it has to be present for at least 6 months to meet criteria. And of course, the person is to show significant distress or impairment in order to meet this diagnosis. Now, Fears, of course, are very common, right? Especially in childhood, but some people don't ever really outgrow those fears. I have a healthy fear of snakes. It started when I was a kid. It's still sort of there, right? But common fears differ from phobias, right, in a number of ways that I think we really just highlighted. For it to be a phobia, it has to be that immediate fear response that's almost always there. You won't really get that with a common fear. You have to have that prolonged and persistent avoidance or intense fear, which is not always there with common fears. And key, I think, is number 6, right? You have to have significant distress or impairment. So a lot of common fears that people have, they cope with them just fine. They don't really leave them feeling very upset, and they don't really impair their life in significant ways. So there are some common subtypes of phobias that are identified in the DSM-5, right? So animals, the animal subtype is common, right? Some of the common ones there obviously are spiders, snakes, bees, kind of flying insects, that sort of thing. Dogs is common in kids, cats sometimes. Natural environment, this is things like storms, right? So some kids are petrified of storms. Heights would be a very common one that you see in a lot of adults. Water, some people are petrified of water, and then being in the dark, typically alone in the dark for some people. We also have the blood injection injury category, which is kind of an interesting one. It actually is fairly different from the other phobia subtypes. First, in that people will usually describe it actually as not really a fear response, but a disgust response, right? So it's not really that I am fearful when I see blood. I'm not scared. It's that I'm disgusted. It's gross. I just can't handle it, right? If I see blood or injuries or the thought of a needle going in my arm, it just feels really gross and yucky, essentially. This subtype also has a unique physiological response compared to the other phobias. So, right, if you are afraid of needles yourself or know someone who is, you may know that, right, that you can pass out, right, with this phobia, which is not something that typically happens in the other phobias. So what happens is you have this initial acceleration in heart rate, but then it's followed by a dramatic drop in both heart rate and blood pressure for people with this phobia, so that they often end up feeling nauseous, dizzy, and sometimes will faint in response to blood or getting a needle. So it has a unique physiological profile. Situational subtype of specific phobias, this would be things like public transportation, going through tunnels, driving over bridges, being in elevators for some people, flying is a big one for some folks, driving, enclosed spaces, right, what some people would call claustrophobia. Right, some people feel like they're, going to get suffocated if they're in a small place, for example. Those would all be situational phobias. And then you have the other category to kind of capture things that don't fit under those other subtypes. So this might be things like a fear of choking, fear of vomiting, costume characters, clowns, loud noises, those types of things. Okay, what do we know about prevalence rates? So specific phobia is actually the most common anxiety disorder. If you look at prevalence rates for each individual disorder, it has a lifetime prevalence rate of about 12%, so fairly high. It is much more common in women than men, which is a statistic we're going to see across almost all of the anxiety disorders. But the age of onset varies widely. So some are very common. It's very common for them to begin in childhood. So animal phobias, blood injection injury phobias, phobias of the doctor or dentist, those commonly occur or start up in childhood. Whereas other phobias like claustrophobia and driving phobia are actually a little bit later, right? Their age of onset tends to be adolescence or early adulthood, for example. Okay. What do we know about risk factors? So we'll start first from the behavioral model, which has a lot of support. So here, the idea is that phobias are a learned behavior, right? And we can learn them in a number of different ways. One is classical conditioning, right? So something that used to be innocuous to us gets paired with something scary happens. You have this bad pairing, and then all of a sudden you start to associate these cues now with a phobia or fear. So this is common in a phobia of choking. So I treated a young boy, he was 9 years old when I was in graduate school, who had a very rapid onset of a choking phobia where he had choked on a hot dog, and very quickly, this was a very scary experience for him, right? So this was the conditioning event. Eating food, right, in this case a hot dog, got associated with this really intense fear. So that after that event, right, he didn't want to eat hot dogs, not surprising. But the problem is that then that rapidly generalized to all different kinds of food. So first it was just meat, but then and then it was just chewy things, but then it expanded to literally everything. So severe that he actually didn't want to swallow his spit. He thought he would choke on his spit. So he was actually walking around with like a bucket that he was spitting into. That was how severe it was. He had lost a significant amount of weight. Obviously, his parents were really, really concerned. So that's a really good example of a classical conditioning onset of a phobia. You could also have observational learning, or what we also call modeling. So you could learn to be afraid of something, not because something bad happened to you in the presence of that object, but because you observed something bad happening to someone else, right, when they were around that object. And so we talked about a good example of this when we went over the behavioral model in terms of the monkeys and snakes, right? So they had, Sue Meinica did this foundational work with monkeys who were reared in the wild versus monkeys who were reared in the lab. And the wild reared monkeys have a natural fear of snakes because they're reared in the wild with snakes. Lab reared monkeys do not have that fear. However, when she had the lab reared monkeys just simply observe and watch the wild reared monkeys respond fearfully to snakes, those lab reared monkeys rapidly acquired the same fear. They learned to be afraid the same way the monkeys that they observed were. Another really good example of this is with Australian marsupials. So there's this group of researchers, in the UK, who have used this paradigm where they take British children and they show them pictures of Australian marsupials that are essentially unfamiliar, right? These kids have never really seen these animals before. They're completely foreign. But when they show them to them, they pair them on the screen, pictures of these animals, with fearful facial expressions. And when you do that over and over again, what happens is at the end of this training, so again, they're not having a fearful response with the marsupial, but they're seeing a fearful face being modeled right next to that unknown animal or unfamiliar animal. And so after this training, these kids will report that they have increased fear beliefs about the animal. And then when they're asked if they would like to pet the animal, so they sort of had this elaborate box set up where you couldn't see what was inside of it. And they had like an iPad in there or an iPod playing like scratching noises. So they told the kid that one of these marsupials were in the box, and they asked them to put their hand in the box. They can't see, just this dark box. Put your hand in there and pet the animal. Not surprising, the kids who had seen the fearful faces paired with the animals were much less likely to put their hand in that box than kids who had seen the animals paired with happy facial expressions, right? So this observational learning was affecting their behavior as well as the fear beliefs that they were reporting. Okay, the last piece that is very, very important in phobias has to do with operant conditioning. So when you're fearful, right, we've talked about this, you avoid, right? So if you are afraid of dogs and there's a dog approaching you, you're fairly likely to just run the other way, right, to get out of there. And the upshot of that is that it's very effective for, in the short term, reducing your anxiety. Your anxiety drops instantly. So that behavior then is negatively reinforced if we think about the operant conditioning, right? So reinforcement means it's more likely to happen again. And it was negatively reinforced because you took something away. You took away the anxiety, right? The anxiety dropped immediately as soon as you left the situation, making it much more likely that the next time you're in a situation, you are again going to avoid, right? You're going to engage in that same behavior because you've learned that it works, right? It helps you get rid of your anxiety. Now, of course, it is good in the short term, very, very bad in the long term, right? So it reduces your anxiety in the moment, but it actually maintains your anxiety over time. And I just gave that away, right? So that's an example of negative reinforcement is the type of operant conditioning at play there. Now, one thing to think about in terms of operant conditioning is, right, if we think about phobias in kids, how might a parent inadvertently positively reinforce a phobia? Okay, so again, reinforce makes it more likely that the response is going to happen again. But a positive reinforcement would be you add something to the situation rather than take something away, right? So negative reinforcement, we talked about, you take away the anxiety when you avoid. What sometimes will happen with parents, and they often do not realize that they're doing it, it's inadvertent. But when a child has a really big fear response and runs out of the situation, a lot of times parents will feel terrible, right? I mean, it's natural. No parent wants to see their kid distressed. So you try to help them feel better, right? Maybe you give them lots of extra love and attention and affection. Come here, dear, it's okay. It's going to be okay. Mommy's here, daddy's here, right? Hugs, affection. Maybe even let's go get some ice cream to help you feel better, right? So the kid is actually getting a lot of positive reinforcement for being fearful and for avoiding. And so the parent is actually inadvertently making it more likely that the kid is going to behave the same way the next time they're in that situation. So something that happens a lot within the family system when it comes to phobias. Now there's a really good amount of research support for both classical conditioning and modeling that these seem to play an important role in the sort of onset of phobias for many folks. But that comes with a really big caveat. Not all case studies can trace fears back to conditioning or modeling experiences, right? So there's lots of people who have random fears or phobias, and they'll just say, I can't ever remember something bad happening with a snake. I have no idea why I have this fear. It's not like I had a bad experience. It's not like I was ever bit by a dog, but I'm still terrified by them, right? So not all of them can link back to a conditioning experience. And in addition, not all traumatic experiences lead to phobias, right? So some people can have really bad things happen in a storm, or when they were at a height, or when they were in the dark, and it doesn't lead to phobias, right? So it's not a one-to-one relationship here. And the reason that is because there are some protective factors, right? So even if you have a bad experience with an object or a situation, there are some protective factors that will make it less likely that you'll go on to develop a phobia. One is if you've had previous positive experiences with that stimulus, right? So if you, let's see, I'm trying to think of a good example. If you generally are the kind of person who loves storms, right? You like thunder and lightning and the sound of rain on your roof. You've had lots of positive emotional experiences associated with that. You are then less likely to develop a phobia if you're in a really bad flood, right? Because you've had a previous number of positive experiences with that situation, right? On the other hand, there are some risk factors that will make some people more vulnerable to phobias than others, right? So if the conditioning situation you experienced was inescapable and uncontrollable, that's going to increase your risk of developing a phobia, right? So if you had a dog bite you and then you were subsequently trapped in the room where it happened and couldn't get out, right? And the dog was continuously barking and growling at you, so you couldn't escape and it felt out of your control. That's going to increase your risk for a phobia. And there are some cognitive factors as well that serve as risk factors. So if you tend to be the type of person who is just in general on guard and kind of hypervigilant for threat, if you are the type of person who tends to overly predict danger, to sort of think more so than the average person that things are going to end in a threatening way for you, and if you have a tendency to underestimate your ability to cope with stressful situations. Those are all cognitive factors that are going to make you more vulnerable to phobias if you end up having a classical conditioning or modeling experience with a phobic object or a phobic situation. Oh, and sorry, one last cognitive factor, catastrophizing. If you tend to automatically think the very worst when something happens, right? You kind of go to the worst case scenario. That's another cognitive factor that puts you at risk for phobias. Okay, so let's think about this in terms of a case study. So Emily and Maria both had traumatic experiences with dogs. Emily was hiking with her own dog when another dog unexpectedly attacked her and bit her on the arm. So she already owned a pet dog, but this other dog attacked her. She was terrified and she had to seek medical treatment for her injury. On the other hand, Maria was walking in her neighborhood when her neighbor's dog growled at her, chased her, and tore her pant leg. Maria's neighbor intervened and pulled the dog away before Maria was injured, so she was not injured the same way Emily was. However, Maria ended up developing a phobia of dogs, but Emily, the person who was actually injured, did not. Now, what are some potential reasons that could explain this? Could it be that Maria's experience was uncontrollable while Emily's experience was controllable? Would that make a difference? Could it be that Emily had previous positive experiences with dogs while Maria did not? So we know that Maria had a pet dog. So could that be a factor that would be important? Is it that Maria has a general tendency to underestimate her ability to cope with difficult situations, and so that was a risk factor for her, while Emily did not have that risk factor? Or is it D, could it be that both B and C are at play? So I'll give you a few minutes to think about that. Okay. So answer we're looking for here is D, right? So just by reading the scenario, you can see that both experiences were uncontrollable, right? There wasn't anything about Emily's that was controllable, so that counts out A. It's possible that Emily had previous positive experiences with dogs. It's actually pretty likely since she owns a pet dog, so she's probably had good experiences with her own pet dog, and we know that's a protective factor. Whereas we know that underestimating coping ability is a risk factor, which is C. So the correct answer is D, both B and C. Okay. There's one other concept in terms of the behavioral perspective when it comes to phobias, which is prepared learning. So the idea here is that primates and humans are evolutionarily prepared to rapidly associate certain objects with frightening or unpleasant events. So it's easier for us to become fearful of some things than others, typically things that evolutionarily it's helpful for us to develop a healthy fear of, for example. So if you, in the laboratory, condition fears for people, so let's say you condition them to be fearful of snakes or spiders, those fears last much longer than when they're conditioned to fear houses and faces, things that evolutionarily there's not much value in us being afraid of. So they tend to lose those fears more rapidly. Also, in that same Sumanica study where the lab-reared monkeys learned to be afraid of snakes by observing the wild-reared monkeys, they actually also showed those snakes, not snakes, the lab-reared monkeys observed wild-reared monkeys responding fearfully to flowers, but they did not acquire that same fear. So interesting, they only acquired the observed fear of snakes, not when they observed the fear of flowers, right? Because there's no evolutionary advantage to being afraid of flowers, right? So there's certain things in our environment that we are more prepared to learn to be afraid of, essentially. Okay. What are some biological causal factors that are at play with phobias? So the serotonin transporter gene keeps coming up again and again, right? If you are a carrier of the S allele of that gene, you show superior fear conditioning, meaning if we bring you into the lab and we try to condition you to be afraid of something, you're going to acquire that fear more quickly than folks who do not have the S allele of that gene. In terms of genetics, we also see higher rates of animal and situational phobias in monozygotic compared to dizygotic twins, right? So remember, monozygotic twins are identical twins. They share 100% of their genes. Dizygotic twins are fraternal twins. They share 50% of their genes. So they're no more related than brother and sister, or brothers or sisters who aren't twins. So if a disorder has a genetic component, you should see higher rates in identical twins compared to fraternal twins, which is exactly what you see here in the animal and situational phobias. The other biological causal factor to think about is temperament, right? So we talked a lot about behavioral inhibition when we went over biological risk factors earlier in the semester, right? So the behaviorally inhibited infant is excessively timid, shy, and as we saw, very easily distressed, right? Especially when they're presented with novel stimuli. And research shows that behavioral inhibition at 21 months of age, so fairly early in life, is related to higher risk of specific phobias by 7 to 8 years of age. So you see 32% of the behaviorally inhibited infants go on to develop a specific phobia versus only 5% of infants who are not behaviorally inhibited, right? So that genetically inherited temperament seems to play a significant role. Okay. So those are the risk factors for phobias. What about treatments? So in terms of treatments, what we know is exposure therapy is very helpful. It is the treatment of choice for specific phobias, right? So if you are going to therapy for a phobia, you should be asking for exposure therapy. I want this treatment because I know it has the most evidence behind it. It's most likely to help me get over my fear. Exposure therapy can involve participant modeling, right? Meaning the therapist is probably going to have to model for you how to be brave and not scared in front of the phobic stimulus, right? So observational learning can work both ways, right? You can learn to be afraid of something by watching someone else be afraid. You can also learn to not be so fearful, right? By watching somebody confidently handle whatever the phobic stimulus is. Some exposure therapies actually also entail virtual reality components, right? So sometimes it can be hard to recreate, let's say, a flying situation in therapy, right? Most therapists don't have easy access to airplanes. So you may use some virtual reality sort of components to help to expose your patient to the situation that they're afraid of. And oftentimes these treatments, these behavioral kind of pieces of therapy will be combined with cognitive techniques. So you'll also be asking them, what are the things that they are afraid of? What are they thinking is going to happen when they're around the phobic stimulus? Because that can be very powerful as well in terms of decreasing their fear over time. If you can show them that what they are afraid is going to happen when they're around a snake, for example, is actually not going to happen if they stay in the situation and let themselves kind of experience what it's like. Okay. So for the sake of time, I'm not going to show you this video in this recorded lecture, but I do want you to watch it. So there's going to be 2 clips here, each about 4 minutes long, so they're not super long. They're really important to watch. So this is basically going to show you what exposure therapy looks like in action, essentially. So in these videos, you're going to see 2 really important pioneers of exposure therapy for phobias. One is David Barlow. The other is Lars-Zorn Oost, who's a Swedish clinician and researcher. And so Lars-Zorn Oost developed what's known as one-session treatment for specific phobias. And this is the idea that exposure therapy is often highly effective in a single 3-hour session. So I've talked with you guys about this before. This is the approach that we used with phobic kids in my graduate program. Lars-Zorn Oost initially did it with adults. So in these 2 video clips, you're going to see an example of a a woman who has a fear of snakes, not just a fear, a phobia. And you're going to see Lars Ornrust doing 1 session treatment with her for her phobia. So a couple things I want you to pay attention to when you're watching this first clip here. Pay attention to what her cognitive beliefs are. So she has some things that she is scared is going to happen when she's around snakes. So pay attention to that. Pay attention to what Lars Ornrust says about sort of some of the effective ingredients, right? He's going to say she needs to stay in the situation, so that's the behavior, in order to learn that what she thinks is going to happen is actually not going to happen, right? So behaviorally, she's staying there. She's going to habituate. Her fear is going to come down, but there's also going to be some cognitive change that happens as well. And just pay attention to her fear response, right? What she looks like initially when she sees the snake and how that changes over time, just over the course of these 3 hours. So that's...
No one has ever died.
The second clip here is just kind of further into the treatment, right? So here you're going to see more of her habituating to the stimulus. And you're going to see her get to actually where the fear is essentially extinguished, where she's saying, I'm touching the snake and I'm not afraid at all. My fear level is 0. You're going to see Lars Zorn doing lots of modeling, participant modeling with the snake. You're also going to see him giving her positive reinforcement, so praising her brave behavior, right, instead of her avoidant or fearful behavior. And he'll also talk a little bit about self-efficacy, right, that she's sort of gaining confidence throughout this process as she kind of learns that she can actually handle this situation better than what she thought she could. So take the time to watch those 2 clips. They're a really good illustration of what this treatment actually looks like.
She decides.
Okay. So one quick question about treatment of phobias before we move on to social anxiety disorder. So Angela has an extreme fear of dogs. Throughout the course of her treatment, she's gone from watching a video of a dog to watching a dog from afar, to standing next to a dog, to finally petting a dog. Angela is most likely being treated using which of the following techniques? Is she probably seeing a therapist who's providing psychodynamic psychotherapy, graduated exposure or exposure therapy, virtual reality therapy, or conditioning therapy? So take a minute to think about that. Okay, so obviously that's a very good example of graduated exposure therapy. Okay, all right, so let's switch gears a little bit to what is essentially another phobia. Some people will refer to it as social phobia, others social anxiety disorder. It's the same diagnosis. In the DSM-5, the criteria for this are that it is the person experiences marked fear or anxiety about one or more social situations that involve exposure to possible scrutiny by others. It's kind of a mouthful, right? So in general, you're fearful and you're anxious about social situations, right? And it's specifically social situations where it's possible that others might judge you, right? So this could be, social interactions, meeting people, talking to people one-on-one in groups. It could be situations where you're observed in some way, situations where you have to sort of perform socially, like public speaking or being in a play, playing in a concert, an instrument, for example. Situations where you need to be assertive and kind of, stand up for yourself. Those are all kinds of the types of situations that people with this disorder would have a lot of difficulty with. And specifically, what they're concerned about in these situations, they're really worried that they're going to be humiliated, embarrassed, rejected, or that they're going to offend others in some way. So that's the specific sort of fearful cognition that they have. Like a specific phobia, these situations almost always provoke fear or anxiety. It's not, oh, sometimes it's okay. This is almost always a problem. Again, like specific phobia, the person will either avoid the situations, or if they can't, they endure it with intense fear. Again, the fear has to be out of proportion to the actual threat, right? Because lots of people don't really like public speaking, right, or performing in front of a big crowd, but this fear response has to be sort of out of proportion to that actual threat. Again, it has to last at least 6 months, and it has to be associated with significant distress or impairment. Okay, so let's watch a quick video. This is Steve, someone with social anxiety disorder, and I want you to kind of take note of the symptoms that he's describing, and then we'll go back to the list of criteria for DSM-5 and see which that he described.
Tell me what it's been like most recently. What do you feel in your body when you start to experience some anxiety in a social situation?
I'll give you some examples, some scenarios where this crops up. My wife and I like to go to dine, fine dining. I would call it fine dining. And unfortunately, the cost of dining does not seem to admit of sufficient separation between tables where you can have a romantic interlude. You're often seated next to someone, you're dining cheek to jowl at a fine restaurant. Mm-hmm. When I'm in a situation like that, I will clam up. It is almost impossible for me to communicate. I get paralyzed.
Even with your wife?
Absolutely. And what happens is that I have this fear. I imagine that people are watching me. They're watching me stumble in my efforts to articulate. Mm-hmm. And typically I'm very articulate. But in that setting, I can be almost rendered mute.
Take me through what happens for you internally as you enter this party. There's a few people mingling there. What happens for you? Your heartbeat?
Yes, I was just going to say, I feel my heart racing. I feel there's a kind of hollowness inside my body. And it's almost like a feeling of a reverberation chamber. Like every breath gets magnified. I sweat. I stammer, which I don't always do, but in that setting I can stammer. I start a conversation, and usually for the first minute or two, I'm on target, where I say something that's amusing, and sometimes humor for me is a way, it's my sort of social grease. But then there's a kind of halting pause after that, because basically my gas tank is now empty, and I don't quite know what to do. And I'm really worried that someone's going to ask me a question that's going to reveal how ignorant I am on that topic. And the biggest fear is that I'm going to appear as ignorant. And it's so counter to who I am, but it still is this distortion of thought. It's a cognitive distortion. Call it what you will, but it's a cognitive distortion that I am going to come across as stupid.
So in that moment when your gas tank has become empty, and you're fearful of the next comment or question that will come your way, what do you do?
I might take a couple of deep breaths. I might excuse myself to go to the bathroom and not return to that gathering.
Okay.
Because then the tank refills, and I go to a different person that I've never had a conversation with and start off with some kind of humorous remark, and then my tank goes to E almost immediately after.
Okay, so a really good description there, I think, from Steve about the types of situation that this comes up in, right? So he described not even a situation where he has to interact with anybody new. He's actually just in a restaurant interacting with his wife, but the idea that other people can hear him, even when he's not directly addressing them, is very anxiety provoking for him, right? And again, his fear is that they're going to see him stumble, right? He's going to be humiliated, embarrassed, right? That's part two. He described clamming up, getting paralyzed, right? That sounds very much like a fear response, marked fear in that situation. Then for the social situations, right, he describes this fear of coming across as stupid, right? Other people are going to think he's stupid, and he tries to use humor. But once the initial joke fades, he's done. He's got nothing else to offer. He's so anxious that, I think his gas tank going to zero is probably like a little bit of exhaustion that sets in when you're dealing with that level of anxiety, right? So again, humiliation, right? Other people are going to think I'm stupid. And then he avoids, right? Number 4. So he said, I usually excuse myself to go to the bathroom, don't come back, right? So you avoid it. And it sounds like these situations are almost always anxiety provoking to him. And obviously they're out of proportion to the actual threat. You can tell just by the way he describes them that they're really not very threatening at all, objectively, even though he experiences them as very threatening.
Tell me.
Okay, what are some of the stats of social anxiety disorder? So lifetime prevalence of around 12%, still fairly high in terms of overall prevalence. Again, it is more common in women than men, similar to specific phobia. This disorder, you typically see it start to onset in adolescence or early adulthood. And many have comorbid disorders such as other anxiety disorders or depression. Approximately a third of these individuals will abuse alcohol to reduce anxiety and fear. And it tends to be fairly chronic. So high rates of alcohol abuse, right? A third is the stat I mentioned. It tends to be associated with lower SES and employment. The idea is over time, for folks with this disorder, they have lower educational attainment and lower employment attainment because their phobia gets in the way of them advancing in school, advancing their careers. They turn down opportunities because it would entail, being under the light more and sort of, being scrutinized potentially more. It also tends to be very persistent. So only about a third of people will recover spontaneously over a 12-year period if you follow people. So this is the type of disorder that you really want to get treatment for early. It's not something that you are going to grow out of, typically, for most people. Okay, what do we know about psychological causal factors? So we know that behaviorally learned behavior definitely plays a role here. So classical conditioning or observational learning will often come into play where someone will remember, an early negative experience. I remember when I was in 5th grade, I had to go up in front of the class to give a class presentation, and I went blank and I stumbled and everybody laughed at me. And people, that person might say that was the start of my social anxiety disorder. I learned to associate public speaking or having to perform in front of other people with this experience of being humiliated and so embarrassed because everybody laughed at me, right? And then it's just hard to get past that. It starts to generalize to other social situations as well. Or, it might not be that you directly had a classical conditioning experience, but maybe you observed somebody else have something very bad happen to them in a social situation, them being rejected or humiliated in some way. And that's enough for you to learn that those situations are scary. That could be the case as well. We also see in individuals with this disorder high rates of exposure to uncontrollable and unpredictable stressful events. So when they were younger. So you'll see high rates of divorce, family conflict, abuse, oftentimes in these people's early history, right? And the idea is if you have had to deal with a lot of uncontrollable and unpredictable stressors in your life, you have a tendency to start to perceive future events in the same way. You start to feel unassertive because it feels like no matter what I do, I can't control or predict these bad things happening to me. And over time, you experience a diminished sense of just personal control over your life. And those things put you at risk for developing this particular disorder. There's a very prominent cognitive model of this disorder that also has a lot of evidence behind it that you should know. And this is sort of it's a depiction of sort of a negative cycle that people get trapped in, where their social anxiety sort of becomes a bit of a self-fulfilling prophecy, right? So start at the top of the cycle, the person, right, expects rejection or negative evaluation when they're in social situations. So they go into the situation thinking, this is going to be bad, right? People are going to evaluate me negatively. They're going to reject me. I'm going to be embarrassed, ashamed, humiliated. The second thing that happens in concert with that is that they overestimate how easily others can detect their anxiety. So they get into the situation, and the minute they start to feel anxious, maybe they start to blush a little bit, and they start to think, oh no, everybody can tell that I'm anxious. Everybody's looking at me. They can see me shaking. They see the beads of sweat forming on my forehead. Right? They overestimate what others are paying attention to. Because they're overestimating this, they actually start to become preoccupied with their bodily responses, right? They are thinking, oh my gosh, I need to stop sweating. I need to stop stammering. I need to stop shaking. And they start to really focus on what's going on in their body. The negative consequence of that is they're so preoccupied with what's going on in their body that it actually interferes with their ability to interact in a socially skillful way, right? So if you are so focused on your body and other people noticing your anxiety, it's going to make it hard for you to just have a normal everyday conversation with the person, right? You're going to miss social cues. You are going to come across, right, awkward, potentially stilted in your conversation. The upshot of that then is others actually are going to end up reacting to you in a less friendly manner because you are kind of coming off, right, as awkward or strange or weird potentially. And so when that happens, that just reinforces where you started, right? If others are not very friendly to you, that is going to reinforce your expectation of negative evaluation, and that's going to increase how much you overestimate how others can detect your anxiety, and so on and so on and so on. And sort of this cycle gets reinforced where because you expect negative things to happen, you actually act in ways that make it more likely for negative things to happen to you in social situations. And again, it becomes a self-fulfilling prophecy. So very powerful cognitive model that has a lot of evidence when it comes to social anxiety disorder. Okay, a couple of biological causal factors for you to know about. Behavioral inhibition under the umbrella of temperament is a really big one, right? So when we talked about behavioral inhibition in infants, it is a precursor to a lot of anxiety disorders, but especially social anxiety disorder. So if you are high on behavioral inhibition between the ages of 2 and 6 years, you are 3 times more likely to be diagnosed with social phobia by middle childhood than individuals who are not high on behavioral inhibition. So it's a very robust risk factor for this disorder. Genetically, twin studies suggest that about 30% of the variance in liability for this disorder is due to genetic factors. So a pretty good chunk, although these same studies actually say more variance in liability is due to learning, right? So that behavioral conditioning kind of factor. So while genetics plays an important role, it seems to be the minority role. And it's actually learning that plays a more important role here. Okay, so quick question here. Matthew was diagnosed with social phobia. Which of the following is an example of observational learning that may have caused his disorder? So observational learning, right, modeling. Would it be that he was teased and bullied as a child? Would it be that he witnessed his friend being teased and bullied after giving a speech to the class? Would it be that he experienced abuse during childhood, or that he has a behaviorally inhibited temperament? So think about that one for a minute. All right, so observational learning modeling didn't happen directly to him, but he witnessed a bad situation, a bad social situation happen to someone else. Okay, so lastly, what are the treatments for social phobia? How do we treat individuals with this disorder? So in terms of reducing the social fears, exposure therapy, again, is going to be the key treatment here, similar to specific phobias. You're going to encourage your patient to face their feared situations and to stay there until their fear subsides, right? They need to habituate just the same way that Miriam habituated to the snake. It's important to do gradual assignments, right? So you're not going to start with the thing that terrifies them the most. You're going to start small and work your way up. And you're going to do a lot of homework assignments, right? Because there's only so many social situations you can recreate in the therapist's office. And at some point, it's going to be important for them to practice their skills in kind of real life social situations on their own. You're also going to use cognitive therapy to both identify and challenge the maladaptive assumptions and thoughts that the person has, right? So one maladaptive assumption that was in that cognitive model, right, is they overestimate the degree to which other people can see their anxiety, right? So you might want to identify that maladaptive cognition and challenge it and see if you can get them to move a little bit in how they think about that. And antidepressant medication will often sometimes be prescribed as well as a way to, again, reduce those social fears. However, the relapse rate with medication is much higher than with therapy, so that is something to keep in mind. The other focus, though, however, with these folks is sometimes they really lack social skills. Sometimes they have the skills, and it's really just the fear that's getting in the way. Other times, it's fear and it's a lack of social skills that are important. So if this individual has been highly socially anxious since childhood and very avoidant, they just may not have had a whole lot of opportunity to develop social skills. And so if you're going to help them get over this, as a therapist, you need to work with them to teach them the social skills that they're missing, right? So you're going to model appropriate social behavior with them. You're going to practice a lot with them so they kind of practice with you in a safe setting. You're going to provide a lot of feedback and a lot of praise, positive reinforcement, but you also might put them into a social skills training group, maybe with other people with social phobia so they can practice with other people. Maybe they go into an assertiveness training group if that's a really big issue for them. Basically, they practice in safe settings, get those skills up to par, and then get out and start to practice in real world situations as well. Okay. So we didn't get as far as panic attacks and panic disorder as I had hoped, and we're pretty much out of time. So we'll end up there with social phobia, and class on Monday, we will pick up with panic disorder, GAD, and OCD. So just make sure that you watch those phobia videos that I didn't show you, and have a great fall break, and we will see you guys in class on Monday. Thanks.